So thank you everybody for tuning in today. We're really excited for this live multiple myeloma task force discussion. We have a very thought-provoking conversation planned today in which our esteemed panelists will discuss mitigating disease burden and healthcare disparities in relapsed refractory multiple myeloma. So for some background for why this panel was convened, the development of novel therapeutic options has significantly improved treatment outcomes for patients with relapsed refractory multiple myeloma, but many patients face barriers to timely and appropriate treatment, including racial, ethnic, and socioeconomic disparities in healthcare delivery and services. This is a challenge that all of our panelists are really passionate about addressing, and tonight they'll be providing a consensus opinion regarding interdisciplinary strategies for reducing disparities in multiple myeloma care. So before we begin the conversation, we'll have all of our task force members introduce themselves. And I'll also point out that if anybody has questions throughout the course of the discussion, feel free to type them into the chat, and we'll have some time at the end to answer everybody's questions. So with that, Dr. Alawadi, I will turn it over to you, and we can take it away.
Thanks a lot, Kira, and thanks for this excellent opportunity. Looking forward to this discussion. I'm Sikandar Alawadi. I'm a professor of medicine with the Division of Hematology Oncology at Mayo Clinic at the Jacksonville location, focused on multiple myeloma care and, of course, healthcare disparity research. With that, I'll hand over to Rahul Banerjee. Dr. Banerjee.
Okay, thank you, Sikandar, for coming, Rahul. So my name is Dr. Rahul Banerjee. I'm about as far away from Jacksonville, Florida as can be. I'm up here in Seattle, Washington, assistant professor of medicine at the Fred Hutchinson Cancer Center and University of Washington, also interested in multiple myeloma. I'll pass it on to our next esteemed colleague, to Mr. Biru.
Hi, my name is Yelak Baru. Thank you so much for the invite and look forward to an excellent conversation. I have the pleasure of serving as president and CEO of the International Myeloma Foundation, and I am also a 28-year myeloma patient, and I'll pass it to Dr. Craig Cole.
And my name is, thanks for inviting me. This is a great panel to serve with. My name is Craig Cole, and I'm a hematologist at Michigan State University, Karmanos Cancer Institute in Lansing, Michigan, and my specialty is multiple myeloma. And I'll turn it over to the most esteemed Beth Freeman.
Thank you so much, Dr. Cole, for that wonderful introduction, and it is an honor to be a part of this esteemed panel. I'm here from the Cleveland Clinic in Cleveland, Ohio, and I am also interested in multiple myeloma, as well as symptom care and supportive research. And Dr. Vita, why don't you tell us about yourself?
Thank you so much, Beth. I'm Shanali Mitta. I'm one of the hematology oncologists at Dana-Farber Cancer Institute in Boston, Massachusetts, and an instructor at Harvard Medical School, and am similarly interested in myeloma, specifically in immunotherapies.
Perfect. So with that in mind, thank you all for taking the time to join us, both as panelists and for the audience, everyone listening in. So we will intentionally, this topic of, mitigating disease burden and healthcare disparities in relapsed refractory multiple myeloma is so complicated. We're going to try to artificially separate them. Obviously, in real life, they're very intertwined. But for the first 30 minutes, we'll kind of really focus on disease burden. The second 30 minutes will pivot more to healthcare disparities and intersection with myeloma care, mitigating disease burden, patient outcomes, and so forth. I think unifying theme here is that we'll be focusing on mitigating them. No one here is going to have the silver bullet, the magical solution that will fix everything. We're probably not going to focus so much on clinical trials and, detailed PFS and subgroup analyses. Really will focus on practical tips, practical concerns, practical issues that come up and how we try to get around them. So with that in mind, focusing on practicality, focusing on mitigating disease burden to kind of start the first half of the session here, maybe the first thing we can talk about is just in general. So again, focus on relapsed refractory multiple myeloma. NCCN guidelines have at least a dozen regimens that can be considered in this setting. What kind of considerations do you go for when you're trying to figure out what to choose for your patient? Maybe in reverse order here, Dr. Mida, Shanali, if I may, since you went last, I'll talk with you. How do you kind of approach this in general?
So I think there's a couple factors that go into looking at how to choose treatments in the relapse refractory setting. One of the main factors I look at is beyond line of care is more so even the rate of progression. And I think that plays a big role in what therapies you can afford in the relapse setting. Do you have time to wait for CAR T manufacturing? Do you have that as an option? Do you not have that as a very aggressive relapse? Do you need to treat with a therapy, off-the-shelf therapy right away? and what is the time afforded to be able to choose that, among the other factors that would go into it. Beyond that, I would say early versus late relapse, medical comorbidities play a large role, and obviously performance status of the patient, as well as their lifestyle, the patient's preferences. Are they working? Do we have to accommodate certain work or lifestyle schedules? And of course, patient preference foremost.
Absolutely. Very well stated. I like that, most of the time we talk about what line of therapy are they on, and you brought up many, many factors that I would argue are probably more important to patients there. Sikander, anything you'd like to add?
No, I think Sonali summarized it very well. Maybe what I'll suggest for our listeners to try to group those factors into 3 different areas or buckets when we talk about patient-related, treatment-related, and disease-related factors. These are very frequently brought up at newly diagnosed state, but frankly, I would almost challenge ourselves to keep thinking about these factors at every single step to try and take the most evidence-based decision. Now, for example, is a patient a candidate for a second auto transplant? We still use it in every now and then cases. Are there any biomarkers or any markers that can help guide their treatment or incorporate some medications? And of course, then, like Sonali mentioned, CAR-T or not, certain kinds of immunotherapies or not, what worked before, what works later, with, of course, keeping our patient and their caregivers at the center of that decision.
Very well stated. I love that framework, 3-part frameworks for everything, this is included. And maybe we can zoom in on that particular point of, patient preference that both of you alluded to, or patient-facing factors. I think one of the other issues is that, the patients whom we happen to see in our clinic, all of us primarily treat or deal with, or are patients with myeloma ourselves, but many of them are being, patients are in the community, they're being treated by oncologists who care for every kind of cancer, who don't see that much multiple myeloma. For those patients, what do you think changes for those patients who be treated in a rural setting or a community setting or somewhere? And are there other barriers or challenges they may face that might alter how likely they are to be seen by a tertiary center, by a CAR-T capable center, and so forth? Maybe, Beth, I can turn to you for that one.
Yeah, absolutely. And I know we're going to discuss later the social determinants of health and the barriers to equal access to therapy. But I think when you're just looking purely at all patients with relapsed refractory myeloma, there's that trajectory of relapse. Is it a biochemical relapse, or the protein slowly increasing from a complete remission, or is it a symptomatic relapse? So oftentimes that dictates whether or not patients are going to go to the next therapy and what that next therapy might be. And then they're relying on the community centers. And that's where I try to get in with that shared decision-making approach. The patient preference is so large, and I'd like to hear from Yelak in just a moment. But a lot of patients just don't want to go to the tertiary care centers until they're referred by that community physician. They're just going to stay and accept the care that's recommended, unfortunately, in many cases. Yelak?
Yeah, thank you for that, Beth. As you go from being newly diagnosed to becoming relapsed and refractory patient, it is common your treatment options become more limited, right? And the complexity of the disease also increases. And as a result of both of that, and hopefully you are now aging or becoming elderly, you may also have other comorbidities that you as physicians need to deal with. I think one of the things that is not often talked about when we talk about relapsed refractory patients is the psychological impact of disease, and actually becoming in the fear of, am I running out of options any longer? So I think it is this time that we really need to think about what is the referral patterns. Are there partnerships that can be established between community physicians and other doctors?
I think that what we had all just kind of mentioned, one in which, have all been super good points. One thing I think is important when we talk about relapsed refractory patients is really asking the patient about what their goals of care are. I mean, we do that all the time when patients are newly diagnosed, and we do that a lot when we really get the multidisciplinary group when people are newly diagnosed. And sometimes as patients go through lines of therapy, a lot of the multidisciplinary part begins to kind of fade away, and we end up kind of assuming what the goals of care that the patient is. I think when the relapse refractory, I think that's when it's most important to have that discussion about, if you're in a rural community, your goal of care may be very different from the first time you're diagnosed until you're, on your fourth line of therapy. That because, one of my patients said that just because you offer doesn't mean I really want that option. And so I think that, getting those conversations, and every time, when I talk to my patients, I say, well, what's your goal? And you don't have to answer that to me today, but what is your goal? What do you want to do? And how do we balance the toxicity and the inconvenience of therapy to its efficacy?
Very well stated, Craig. I agree. And I'll add that, as for many of our patients, not all, but many of them do have caregivers or loved ones as well. And it's kind of a three-way decision process there, where I've sometimes had cases where the, patient is kind of reluctant to, try bispecific antibody or try moving somewhere, but the patient's partner is like, nope, whatever you say, I will drive there. In Washington State, we have mountains. They're like, I will drive over all the snow, all the mountains on the entire state to get her there every single time, something like that. And it's hard, because I think then there's also those interpersonal dynamics between the patient and their partner, and they both are living with this diagnosis, and that makes things tricky.
Rahul, one of the things we did not talk about, probably we'll also bring this up when we talk about social determinants of health, is as you go through lines of therapy, your opportunity potentially for a younger patient like myself, your potential to continue to earn and to continue to be covered by insurance may become less and less. And as a result, your access to those tertiary centers may be more limited. And so I think that also needs to be factored into the discussion of treatment availability for relapsed refractory patients.
Very, very well stated. Yeah, one of the hardest questions that I have to face with my patients is not prognosis. It's like, what health insurance should I get for next year? Cool. I got nothing for you. Maybe before we move on, I'll briefly allude to something that I found to be helpful for these patients who live remotely. I've actually found patient support groups to be very helpful, either through the International Myeloma Foundation that, Yelak is speaking very astutely to, or, in the Pacific Northwest, we have the Pacific Northwest Myeloma Fighters. And I've been surprised. The patients come to me and be like, hey, can I switch from zoledronic acid to denosumab? And I was like, oh, yeah, where did you learn about that? They're like, oh, from this other patient. And obviously it's a discussion clinically, blah, 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 non-inferiority. But it's like, great. I think hearing from other patients sometimes is so important to realize that it's okay to say no to a treatment that you were offered by the physician, to the point that Craig made, or maybe it is worth going to consider blah, blah, blah therapy or a salvage auto or something like that at an academic center.
Along those same lines, I think it's also useful through support groups or speaking to other members of the community or within the myeloma community as to, whether to ask for a referral or not. Some patients may not know that you can ask for a referral to a tertiary center. You don't have to wait till disease is aggressively relapsing. It actually may be better when it's a slow biochemical relapse. That might be the ideal time to go. So there's no set time point that one has to wait to get to ask for that referral or be referred to another center or ask for a second opinion. In my experience, I've never been offended. I've never had a colleague offended when they ask for a second opinion. If anything, more minds, the better.
Totally agreed. Wonderful.
I think sometimes we do have to give our patients permission to ask that. Is that sometimes, patients, they don't tell me that they're worried that they're going to offend me if they ask for a second opinion. And so I bring it up. Every time, we give a packet to patients that we see here at Michigan State. And on that packet, it says, about a second opinion beyond where you are now. And even when when I'm the second opinion, I say, maybe we should talk to somebody else. And I give them permission to go see other people.
And just briefly along those lines, I wanted to add about how from the academic centers, I give my patients permission to seek out a community person. So if they're driving 2 hours each way, they came for an opinion, they have trust with us, we're giving them this novel therapy. I say, you know, they can give you this in another state and it's okay. I'll communicate with them. We can manage and communicate virtually even, you know, Zoom in with me in like 3 months and we'll stay connected. And so I think that provides comfort because down the road, bispecific antibodies, CAR T-cell therapies, and all these novel agents need to really be given in partnership with the larger community centers, at least in the beginning of administering these.
That's an excellent point. Especially, I mean, and even the newly diagnosed or someone who's diagnosed with when the relapse is an aggressive, you know, extramedullary lesion, they end up on the, you know, tertiary center's neurosurgical service, and they see me, and then I'm like, oh no, you can go back and so forth. So I agree. I probably, as many patients as I get referred to me, I probably send half as many back out into the community to have a local, you know, community oncologist co-managing them. Maybe in the interest of time, we could move on, you know, to a point that Shonali, I think it was you who had alluded to earlier. Maybe I won't pick on you right away. I'll start with Craig first, but you brought up early versus late relapse, and people can use that word 2 different ways. Some can say that, you know, functional high risk is early relapse versus late, but historically early versus late was like, you know, 1 prior line, 2 prior line versus like 3 to 4 prior lines, etc. Maybe we could just talk about lines of therapy. I know we poo-pooed them earlier, but do you approach anything differently? Maybe I will start with you, Shonali, if you don't mind that, because I keep name dropping you here. But, you know, for someone who is now on their first relapse, first time ever relapsing, do you approach that care differently than you would for someone who's had, you know, 3rd line, 4th line, 5th line therapies being considered?
I think so. I think you have to approach it somewhat differently, right? So it goes back to those patient-related, treatment-related, disease-related factors. Is how quickly is the patient relapsing? Is it a first relapse, but it's very aggressive? It's within, you know, less than a year from transplant, then I might be more apt to choose a quadruplet or at least a triplet in that line that, you know, I think would be very active based on what they were responsive to in the first line, whether it was IMiD-based, immune modulatory-based, or proteasome inhibitor-based, or whether they have or have not seen a CD38 monoclonal antibody at that time point. Versus a later relapse, I would shy away from using line of therapy. I'd rather use class refractoriness. But I think, you know, that does play a role into it. And we are also, at this time point, limited by FDA label, too, for many of the novel immune therapies. So that would, again, play a role in what therapy I would consider in that later line relapse, especially as CAR T and bispecifics are only approved in the US in 5th line and beyond. That being said, if I'm concerned about that at any line of therapy and the option is available, clinical trial.
Yeah, and I always keep my eye kind of open, you know, when I'm, you know, one thing I think that we agree on is that, you know, really, you know, quads up front are becoming, you know, really the standard of care. And I think Perseus is going to show us that at ASH this year. So we're going to have a CD38 kind of already done in the bucket. And hopefully, you know, there'll be, you know, a year or 2 years before someone is refractory in their second line of relapse in their second line of therapy. But even then, I'm kind of thinking that, you know, I'm going to use a T-cell mediated therapy, you know, down the line. And I don't want to be, you know, up against using chemotherapy when I'm going to be using, you know, I don't want to use chemotherapy as a bridge to get me to a T-cell mediated therapy. So sometimes, you know, in the 2nd or 3rd line, as I'm going through, you know, the therapies, sometimes I will combine, you know, Cytoxan with Cytoxan with one of the proteasome inhibitors, or carfilzomib, and trying not to use those, you know, up against using a T-cell mediated therapy.
Very well.
As a patient,
go ahead. Yeah.
If I can add, if I ask each one of you and tell you what treatment I have been on, the lines of therapy you will tell me is different. And the only right one probably is my insurance company, who will end up approving that particular drug or drug of combination. So I really think the point you made, Shonali, that we need to go from lines of therapies to classes of therapy, refractoriness is really important. And also, as you doctors tell us, we need to employ the best therapy available early. I think we also need to think about not just, the first relapse or the next 2 years, the next 5 years, but patients like me who have been on therapy and off therapy for 25 years. If you are going to deploy 4 drug combinations, how are you going to pace yourself or the patients for them to actually be alive and for you to have that problem of giving them whatever is, car squared down the line?
Very well stated. So actually, maybe I'll build on that point a little bit, because you brought up earlier that there are a finite number of new treatment options. They start to diminish as, patients go to 3rd line, 4th line, 5th line, even with our clinical trials. So let's talk about sequencing. So maybe, or I should rephrase, recycling those therapies. And so, how, if ever, do you recycle previously used therapies? I think the biggest one that comes to mind in my mind actually is CD38 monoclonal antibody, daratumumab or isatuximab. It comes up a lot, right? Because darapomdex, dara-KD, or isapomdex or isa-KD, etc. Maybe, Sikandar, I can ask you first. Any advice or wisdom for how to sequence therapies, and maybe particular emphasis on CD38s?
Excellent point. And by the way, this discussion is so exciting and covering so many topics that are so practically important. So, Rahul, you're right. As Yelak, you mentioned that it's important to figure out what are we using, how do we pace ourselves, how do we get every single drop of benefit out of every single regimen. And that's when we see outcomes like you mentioned, 28 years with myeloma. My longest survivor right now is, I think, reaching 33 years or so, and in fact has not been on treatment for the past 2 or 3 years. So what we have to figure out is how to sequence, like you said, Rahul, and how to bring some of them back. Now, we've not had a whole lot of data on retreatment or recycling some of these drugs. Historically, proteasome inhibitors had some data, and that has been kept in mind. But the bottom line is when we are creating these lines of therapy, sometimes that recycling becomes necessary. In the US, for example, I keep saying that while, as Shonali mentioned, CAR-T bispecifics approved 5th line or beyond, well, frankly, if we use evidence-based medicine, it's very hard to come up with a 4th or sometimes even a 3rd line of legitimate therapy. We've kind of exhausted things. So there is some data to suggest that for a CD38 antibody, at least some lab-based data and some clinical data, that you can bring these back after a sufficient gap and you can consider trying them again. At least some data suggested a year gap. We have a clinical trial, for example, going on with isatuximab, where they are allowing patients to go on to ISA after they have had at least a 9-month gap from the prior the CD38 exposure. Now you can say 9 months, 12 months, 6 months, what is the magic number? I don't think, unfortunately, there is any. But important thing to keep in mind, just like Yelak and Shonali were mentioning, that refractoriness to a class of drug or exposure to a class of drug is important. We talk about quads in the front line. In the real world, very frequently, patients are getting these quadruplet therapies for a few cycles, 3, 4, 5, 6 cycles. Then they get their transplant. And in the real world, frequently, the maintenance is not including a monoclonal antibody. So it's important to keep in mind that if that patient is progressing and they have not had a monoclonal antibody for, let's say, a year or so, it is absolutely legitimate to bring it back and hopefully get that same depth of response that we have seen in clinical trials when we use these agents in the relapse refractory setting.
I agree 100%. And in my experience, 20 years ago, we had thalidomide, melphalan, and prednisone. And now we have this embarrassment of riches, and we are still learning the best way that we can use each of these these therapies. I do go back to CD38s after a treatment-free interval, especially if they've just been exposed but not refractory. We're learning more about different classes of drugs, and we had the bortezomib retreatment data back in the day as well. But again, trying to pull back on therapy when you do the induction, it's usually a 4-drug, transplant if eligible, and then some form of maintenance. So absolutely, in those patients, we're going back, but also a well-designed clinical trial. That's my plug, to put in for a well-designed clinical trial in those patients that are exposed but not refractory as soon as possible.
Agreed. And I'll add that, you know, in the future, it may not be a time-based threshold. We may have some fancy new technology. I mean, it exists, right? And there was a paper out of University of Colorado earlier this year with ex vivo drug sensitivity testing, you know, where the idea is that let's not wing it 6, 9, 12 months. Let's actually look at the cells or use patient-derived xenografts, whatever, very high tech, and figure out exactly, is it time to resequence CD38 or bortezomib or anything? So time will tell. You know, speaking of fancy new technology, I feel like no discussion about myeloma can proceed without a mention of MRD. I think this is the first time I've mentioned it. No one mentioned it yet, so great. So measurable residual disease, right? So kind of by the best technology available to, I always say, to humanity, but to possible, you know, can you pick out 1 in 100,000 or 1 in 1,000,000 or maybe even 1 in like 5 million, maybe 1 in 10 million cells? In the frontline setting, studies like the MASTER study is one of the biggest published ones to date, showing that you actually can use MRD-guided decision-making to de-escalate therapy. What about in the relapsed refractory setting, where we typically keep people on therapy for years? Maybe, Yella, because you have very literally lived through this, what is your approach? What would you recommend, you know, in terms of, would you ever use MRD or really anything to de-escalate or stop therapy for patients where the myeloma has relapsed before?
You know, with the concept of give the best therapy early, but then also the overall acceptance of treat until progression, I don't know, to answer your previous question, I don't know what the options of retreatment is if I'm actually being, I don't want to call it maintenance, because most of these things are really treatment with a reduced dosing schedule until you end up progressing with, hopefully, as Dr. Cole said, managing the toxicity and the quality of life. But I really think, you know, for a patient like me who has been around for many years, especially in the relapsed refractory settings, you can probably use previous treatment responses in order for you to feel comfortable that you can de-escalate treatment, and then you can still catch the myeloma before it becomes full-blown. So it may depend on Shonali's answer earlier of how quickly you end up relapsing. And then there may be other factors you should be considering from biology perspective. You know, what is the risk of relapse? What is the patient's preference? Do I want to take that risk of progression, but being on therapy-free, because I want to go see my mom who's 84 years old and I need to travel outside of the country for that to be able to do that. So I think it really is a combination of science, art, and patient preference, in my opinion, that will end up informing you what you can do in addition to the science. But we have talked about MRD like for years, and I'm hoping at some point we'll have the answer.
Yeah, gosh, everything you said was just like poetry. I mean, that was like awesome. You know, we already have a therapy that has, you know, super good responses that we discontinue, de-escalate immediately, and that's the CAR T. I mean, we already do that, and that is kind of based on the effectiveness of the therapy and being able to really take that deep dive. And we're getting there with some of the bispecifics that, you know, at ASH this year, abstract 1010, which I thought is a kind of a cool number. I wish my abstract would have a cool number like 1010, but it talked about de-escalation of talquetamab from every 2 weeks to every 4 weeks based on just response. And already, you know, in Europe and at ASCO, I think this past year, there was teclistamab de-escalation based on response. And so I think that some of the de-escalation of treatment really is a bit dependent on how well these therapies work and the new technology. The board's question, answer is going to be that if you have like a standard myeloma therapy, that you continue it on in the relapse setting. But I'm hoping as our therapeutic technologies get better, that we'll be able to use the MRD technology to be able to do exactly what you said, where we can discontinue therapy.
To provide a slight counterpoint here, I think, when it comes to MRD negativity, while it is very useful for prognosis, especially in sustained MRD negativity, right? So 6 months or greater, I think understanding its utility in de-escalating is slightly immature at this time point. I think, I always tell all my patients as well, if you put 10 myeloma physicians, or in this case, 6 in a room on this topic, you'll get about 12 different opinions. And so, it's something that we can debate back and forth, but I think to jump on what Dr. Cole said, I think it also does depend on the therapy the patient's on. When it comes to a T-cell mediating therapy, it may be more than just MRD negativity. I think our technologies can show us, T-cell milieu and other immune milieu and the microenvironment, and is that allowing for recovery of a normal immune environment in which you're not seeing those exhausted T cells, and that can also then drive schedule of bispecifics or CAR T therapies while mitigating the other risk factors like infection risk, especially.
Sonali, you bring up excellent points. And I think the exciting part about care for myeloma is that there are at least now trials being done to specifically answer that question. Can we de-escalate? Can we stop? Because frankly, it's the patient preference, we said, it's a patient-centric approach that needs to happen. Historically, there have been more kind of drug-centric approaches. But now we are getting, at least in myeloma care, where we are bringing in more of patient-centric approaches and seeing how the patient kind of plays into that much more importantly. Okay, so as Rahul, you had mentioned in the beginning that we're going to kind of arbitrarily divide into myeloma care and then healthcare disparities. So maybe with this, we'll pivot to that second portion of talking about healthcare disparities a little bit, which is so near and dear to all of us who are on this discussion, and we've all done a lot of work in this area. Now, data in myeloma care has nicely shown that under equal opportunity settings, and the two that have been highlighted have been either the VA or clinical trials, that when the patients get exposed to these equal opportunity settings, a lot of the healthcare disparities kind of melt away. And in some cases, our underrepresented populations tend to perform even better than the majority non-Hispanic white or just, you can think, urban or those larger groups. So let's now talk a little bit about these healthcare disparities and how those play into this extremely complex decision-making process that all of us are talking about, at least in the first part of this talk. So maybe, Craig, I'll start with you. When we talk about racial and socioeconomic disparities, just focusing on, let's say, the time of diagnosis in myeloma, talk to us or talk to our audience about which one of these disparities do you think become important and how they play into the patient's beginning of journey with myeloma when they get diagnosed.
That the time from first symptom, there's papers that have been written showing the time from first symptom to the time of actual diagnosis is 100 days, which is, I think, an incredibly long time to have symptoms and to have this disease. And when you factor in our race, that of the patients that had, these long delays, 62%, the highest, group that had delays in diagnosis are African Americans. And Blacks have also, been shown to not have complete diagnostic workups and Blacks in the United States have also been, had inadequate, staging, and some patients told us staging isn't important, that there's no point in doing staging or risk assessment. And I would definitely say, in my own experience, I have seen that play out. I had two patients of identical age, identical presentation. The white patient had her daughter with her, and she and her daughter pressed her doc into getting an MRI when she had back pain, et cetera, and was diagnosed easily within less than 30 days. And both of them came to me, and we started, the workup and then got her treated. As opposed to the Black patient who went to her doctor with back pain, and then her doctor didn't listen to her, and she was referred to a chiropractor, who then did some x-rays and didn't find anything. And she came to her appointment alone. She didn't have anyone advocating for her. And it took almost 3 to 4 months, and she had a spinal cord compression by the time she was diagnosed. And there was a tremendous delay in diagnosis. And she was told that, the reason that your kidney function is getting worse is because you're diabetic and you're obese. And none of that was true. And so I think that it's just, it is in part the way that doctors are sometimes trained about how they talk to patients. And, that there was a study that I thought was really kind of shook me, that doctors of the same race spend time with their patient of the same race than doctors of different races having different patients, patients of different races. They spend less time with those patients. And it really shouldn't be that way.
I really think this is a critical discussion item for us. You mentioned that African Americans can achieve equal or better outcome when receiving similar therapy compared to Caucasians. And Dr. Cole, you really eloquently outlined that longer time from symptom to diagnosis for African Americans. I think there are a few other data points we probably should call out for our audience, which is African Americans are younger by about 5 years on average at diagnosis, right? And the myeloma and MGUS in general is twice more common in African Americans than Caucasians. And African Americans are also less likely to receive, the 3 T's, the transplant, the triplets, and the clinical trial. So when we also talk about socioeconomic disadvantage, if you would, people think, or sometimes it's associated with poorness. It really isn't, or it's not. Poorness may be one of the manifestation of it, but one of the things that we have done with the NCCN recently published a recommendation is that there are 4 key socioeconomic screenings that we need to do. One of them is access to transportation. And it could be, do you have a car, or do you have a gas to fuel your car, or can you afford parking? The second one is housing. Somebody mentioned someone who's coming to their clinic was actually living in their house. So when I asked them to do something in their home as a physician, I didn't really put that together, that they don't have a house to go to do what I'm asking them to do. And then the other 2, and I can yield the floor back, is access to food. And, food and cancer and outcome in general have reciprocal relationship with each other. Not having good food may cause cancer, or not having good food may not allow you to have good outcome from your cancer. And then the last one is really financial security, as I'm sure we'll talk more about.
Go ahead, Beth. I was going to actually call upon you to build upon that.
I was going to go right into I think you raised some excellent points about misdiagnosis, delayed diagnosis, and suboptimal care. And unfortunately, clinician bias is a reason why some of these disparities do play into preventing patients from getting the optimal first-line therapy. We have data to support that 4 drugs are better than 3 drugs. And unfortunately, that clinician bias, this person won't want to drive in, or they don't have good insurance, or they don't have a caregiver. So there are many different barriers, such as that belief that they're not going to adhere to therapy. Also, playing into the adherence, when you prescribe these 4 drugs, you have to prescribe the supportive care, right? So they have to do the acyclovir to prevent shingles, DOAC if they're on like a KRD type of a regimen. And so all of these play into them maybe not getting the access that they should, or the best care that they should. Shanali, what do you think?
I would agree. I think really to work on breaking down those barriers is empowering the patients and providing as much information, which is truly part of our job, right? Is one of the ways we can get at breaking down those barriers is saying, okay, this is the information that I can give you. You are the driver in the driver's seat. You make the turn where you want to turn, but this is the roadmap, right? And I think doing that across the board for all patients is what we should be doing. That doesn't mean it happens with every patient, but that should really be the goal that we try to attain. So all those things still play into it. There is the bias that if a patient has not established at the primary care and doesn't have their diabetes under control or their high blood pressure under control, am I going to prescribe something like carfilzomib that has a higher risk of cardiac dysfunction? Maybe not, but it's something that you need to discuss with the patient first before making that decision for them, right? And so I think that's where taking the time to discuss with patients, as difficult as that is in this day and age, is crucial.
I totally agree. That is the best statement, because we are rushed. It seems like we are rushed. Even though we have an electronic medical record, which should make our lives super easy, we are rushed. And what I always have to do is I have to slow down and really get, and I kind of tell our fellows this, to get a good social history. Not just sit there and read the social history that was in the EMR from the emergency room visit, but really find out the what is happening inside this patient's home. And we have social determinants of care assessment tools that come in, and I read that, and all my myeloma patients know our social worker by first name. But in addition to that, I see who when you're at home and you talk about your disease, who do you talk to your disease with? And if they say, well, I don't have anybody, then I say, well, we need to really build a team around you. And I make sure that the patients have permission to be decision makers in their care, especially a lot of my older patients, like, do whatever you want to do, doc. And I always say, we can't do that. We can't do that. But the only way you can do shared decision making is to know the person you're sharing the decision with, not just throwing options at them, willy-nilly.
And I think that also goes back to it goes back to Dr. Cole's point earlier of, a patient may feel intimidated or in some cases embarrassed to bring it up to their physician, in which case it's incredibly important to involve your nurses, involve your social work, your care manager, colleagues, because sometimes that barrier is not there with them that they may feel with you, and they can be more open and then get the information still relayed to you and find a way to then comfortably bring that up in conversation.
Yeah, and briefly, I know we're tight on time. We're just so excited, but I always involve the multidisciplinary team, just like Dr. Cole and everybody mentioned. That social worker might be that person that one responds better to, and really just working together and building that team can really help that patient, bridge that gap between suboptimal care and the best care that they can receive.
That's, I think, building upon what Craig mentioned about EMR, et cetera. I see it's important for us to acknowledge the fact that, yes, everybody's pressed for time. Like Craig, you mentioned, we're all rushed. There is just so much pressure, practice, institution, research, education, everything, and family. Frankly, all of us have our own try to with that work-life balance. So I think it's a good idea to develop some triggers. We've all talked about utilizing the EMR to our benefit. So for example, in our clinic, what we've done is when some of those we don't have resources to have a social worker involved with every case. So when certain trigger is noted in the chart, the social worker comes in, because frankly, Rahul, you mentioned, it's hard for a clinician to talk about the right insurance plan. We are in open enrollment season, so patients frequently ask, what should I do? I'm sorry, I don't know, but let me connect you with someone who might be able to provide you an answer. So, Beth, to your point, developing this multidisciplinary team to help sort out these issues for the patient so that they can get evidence-based care, right? That's so important. So,
and that mitigates a lot of these racial, a lot of the things that we talk about. Sikandar said, in equal therapy, equal outcomes based on race. And the way to mitigate that is that you have to pivot for each patient. That you can't, just because I've made the mistake of having a patient who looks like me and assuming that they have the same social, economic, everything that I have at home. And that's not true. I have to say that investment that you make in sitting down with the patient and learning who they are pays off in the end, where you can sit there on maintenance therapy and joke about kids and how they won't do the dishes and things. Like
so as you go to the next topic, what I'm also hearing, and we probably may not have called it out, is really the need to trust me, to trust you as my provider, as my doctor, and make sure that we overcome the mistrust or the distrust issues that we have, especially in the underserved community. This also requires, educating. You guys are very invested, and you have built a team around you that is very invested in making sure that they're able to address this. But we may need to ensure that there is social need training that is available for other providers. And we need to be able really to address this bandwidth issue, not by us asking you to work longer, but maybe we should have a policy to allow reimbursement for social screening and then the associated services that you are going to provide. So then you can actually hire a nurse or a social worker in your clinic for you to be able to make sure that you are providing that service.
So, in fact, Yelak, as you're mentioning, Rahul, what are your thoughts about some of these kind of logistical disparities about patients that Yelak is pointing out?
Yeah, agreed. And so, just one thing I'll add to the question of kind of screening. I think there'll be depending on when people see this, there either will be or there was an oral presentation at ASH about a randomized trial of financial toxicity screening or with a financial navigator, and that seemed to work. Patients who had it, you did see a slight improvement in their cost scores and inventory of financial distress. And so, it's not just identifying patients at risk. You actually can do things about it using a multidisciplinary team, which is great. I think maybe the only thing I would add in terms of other logistical disparity, we haven't really we've talked a little bit about patients who are driving, willing to come again over to snow, over to mountain, through a hurricane, whatever part of the country you're in, there's something going on with the weather to get here. But I think driving distances or transit distances, I think should briefly be mentioned, because I think they are a big issue for many of our patients. They are honestly probably one of my biggest criteria for CAR-T versus bispecifics. In every conference, the debate, CAR-T versus bispecifics for myeloma, and how do you decide? And honestly, driving distance is a big part of it for me. So I would say the other thing that often the multidisciplinary team can help with is that they often, usually our nurses, and if you actually probably hear from the patient a bit more, that man, like they are traveling 4 hours per infusion to get here. Hopefully you already know that, like correctly, you've actually understood what's happening and how difficult it is to arrange transportation. Their adult child will take time off from work to come drive them to appointments and so forth. But if you don't, often our nursing colleagues catch it. Often even some of our pharmacy colleagues catch it during some of the issues with lenalidomide, being like, oh, their pharmacy is just not, pharmacy games with them or so forth. So I think what I would say is, in terms of other disparities, besides the ones we've alluded to, I would just think about the idea of time toxicity. For patients who are on active treatment, newly getting therapy, just started for new line of therapy, they will move heaven and earth to come in to see you every single time that you ask them to for treatment. But when they're on maintenance, do you really need to see them? Do they really need to be getting lab work, multiple times per cycle for a patient's reproductive age? Do they really need to be getting their urine pregnancy tests in clinic and to do them at home? Can they go to a lab close to them to do it? Things like that. I think that if you don't think about those, you'll miss them, because you just see the patient in your clinic room in front of you and you've missed everything that's happened outside of that space, time-wise and space-wise. And I think it's hard. We're all busy, but I think that's often where my team members, they're the ones who suggest like, hey, let's space them out, or honestly, they missed that dose, or hey, it's Thanksgiving. Do they really need to come in for their cycle 16 day 8 of Velcade or bortezomib? Nope. So I think it's helpful to work as a team on this.
So this is very, very interesting, and we're going into some very interesting topics. Like you had mentioned, the 3 T's of disparity. Unfortunately, in my mind, those T's seem to be increasing, whether it's time to treatment, triplet, transplant, CAR T, or also trials. And unfortunately, all of these T's, there is data to support that there is a lot of disparity. And as we come up with these newer, more complex, more involved options, in some cases, I would say it seems that that disparity gap is even widening. We have, for example, a couple of programs that working towards. And by the way, Yelak, I think I should congratulate you on saying when you mentioned we should be looking at policy changes. So we have a few trials running where we are doing what we call cancer care beyond walls, and those trials are being used to administer clinical trial drugs at the patient's home. But the biggest issue is reimbursement. So the institution is supporting right now, hopefully to be able to get to the point that reimbursement can be created. But on that topic of trials, we have not touched upon the clinical trial related disparity yet. So maybe, Craig, I'm going to ask you, and then Beth, both of you to kind of take that on and see what do you want to share with our audience regarding disparities for clinical trials in multiple myeloma?
It wouldn't be a Zoom meeting if I didn't mess up the microphone. I talk to our patients is that when you look at a clinical trial, is the patient in front of you represented in the clinical trial that you're looking at? Because if they're not, then you can't guarantee that you're going to get the same results in treating that patient based on what that paper says. And we know that the FDA has looked at this a couple times, looking at drugs that came for FDA approval and the clinical trials to support them. And the average number of Black patients enrolled was, 4.5%. And in the most recent analysis that the FDA looked at, the number of elderly patients of over 80 was again, less than 10%. The number of Hispanic and Asian patients from the United States was very low. And so, with the number of Black patients in the United States with myeloma being in the 18 percentile, the fact that, in these registration trials having only 4.5% is a huge problem. And the FDA knows that, thank goodness. And I think that our colleagues that are doing, the pharma and sponsors of trials and investigators are aware of that and are really taking action to try and bring clinical trials to more diverse populations, not only based on race, but based on ethnicity, gender, and age.
And along with that, I think it's important to highlight not just clinical trials, those are dismal numbers, by the way. Who's sad to hear about 4%? But the other piece of that is CAR T cells and bispecific. So I have patients in my clinic that are Black, and nobody's talking to them about clinical trials in the community or talking about bispecific and CAR T cell therapy, because that clinician bias, unfortunately, that implicit bias, maybe you don't even know you have, you don't think you're not offering the same or effective treatment, but just bringing it up to them, not assuming that they don't want to go through this therapy, just bring it up to them. with clinical trials, you might think that they don't want to drive an hour each way, but maybe they do. Like Dr. Banerjee said, they'll go over mountains and they might be willing to drive if you are recommending it and they have trust in you as a provider. And I applaud a lot of our pharma companies are now only including arms of clinical trials where they're done enrolling all of the white and other patients and only the Black patients and other demographics are being enrolled. But the last thing I'd like to ask for the pharma companies and the clinical trials, even in the investigator-initiated trials, translate the consent forms. If I have a Spanish patient in my clinic, but I don't have that consent form in their native language, they can't be accurately consented for that clinical trial. So removing that language as a barrier can really help enhance enrollment, I think.
Excellent.
I think one important point that I've heard is, well, Black patients and Hispanic patients don't want to participate in clinical trials, and that's absolutely wrong. There's clear data that shows that, in fact, Black and Hispanic patients and Asian patients are more likely to want to be on a clinical trial than white patients. And the main reason for non-participation in clinical trial was lack of interest. And the lack of interest that ownership is on the provider and the physician, not mentioning them the clinical trial. And at ASH this year, there's an abstract that had a focus group of myeloma patients and asked them about clinical trials. And the Black myeloma patients were willing to participate in clinical trials, regardless of prior experience or knowing anyone that has been on clinical trials. So I think that the old idea that the history of injustices, I mean, we are very aware of that. As a Black person, I am very well aware of the history that's taken place, but I wouldn't let that history impair anyone from recommending and talking about clinical trials to Black and brown patients and to women and older patients also.
Skander, as you go to before you go to the next item, if I can add one thing, right? One of the limiting factors, in my opinion, or I should say two of the limiting factors in patients in the underserved community that is preventing them from participating in clinical trials are two. Clinical trials do not exist in the catchment area where they live, right? So we need to make sure that we bring clinical trials where the patients are, as opposed to us asking to move the patients, and it's like, the mountain and the Muhammad thing. The second one is really, we need to make sure that we broaden eligibility criteria. And some of the eligibility criteria are, in my opinion, like from the 90s or early 2000s. And I'll read this. This is an eligibility criteria I recently reviewed, and this is what it says. Patient must not have any serious medical or psychiatric illness that could, in the investigator's opinion, potentially interfere with the completion of treatment according to this protocol, right? So this is, in my opinion, very ripe for investigator bias and potentially not inviting patients that don't look like them into a clinical trial.
Yes.
Excellent point, Yelak. That is so powerful that you bring this up. But I'm glad that some of these so first of all, I'm glad that we're discussing about this. I'm glad that we are bringing out these issues. And then there are some recent efforts which have been going on to try and overcome that. But Shonali, to your point, you mentioned it is very important to at least lay out the options. Even if we think that the patient may not go down a certain road, it is important to at least discuss everything, and only then we can take an informed decision. We did a study about 500-600 cancer patients at Mayo and asked them about clinical trials. And Craig, to your point, the number one difference that came between African Americans and whites was lack of awareness of trials. Now, this is a pre-selected group. Patients are coming to Mayo Clinic, large center, seeking care. But the number one reason was not bias, not fear, not anxiety, not nothing. It was awareness. So people were not being talked to about trials. But now we've talked about so many problems, so many issues, so many passionate discussions around this topic. I'm sure there's a silver lining somewhere. So let's take a few minutes and talk about efforts that are underway to try and mitigate some of these. And what I'm going to do is first maybe go to Shonali, and then I'm going to give you the last word on that topic. But I really want our audience to hear about what is being done to overcome some of these disparities. So Shonali.
Absolutely. And I think different people have touched on different aspects of this already. One is absolutely increasing access, is opening trials in collaboration, not only with academic centers, but even larger community-based centers like US Oncology or larger private groups that have a large encatchment area or wider reach than an academic center may have. Beyond that, I think focusing treatment or clinical trials in treatment groups where it's applicable. So we know that Black patients have a higher proportion of translocation 1114 in myeloma, and focusing those 1114 targeted drugs in those populations for those patients. Beyond that, again, access at home and introducing digital health tools or other tools within a clinical trial to allow for treatment at a patient's home, as opposed to having to come in those 1 or 2 hours to the clinic. And then beyond that, as you were mentioning, I think Yelek mentioned this, was changing eligibility criteria and really taking a deeper look at what's preventing us from putting patients on these trials. So one of those that was looked at was looking at Duffy null status, which is the likelihood of a patient having a lower white count, which oftentimes can meet an eligibility or exclude a patient from a trial because of the underlying low blood count. And understanding that that's not a function of disease, but that's a function of something else. And creating an eligibility criteria that allows for those patients to still be on study and to even look at those. So there is, I think, also at ASH, by one of our colleagues here, in collaboration with the determination trial, looking at specifically African-American patients and Duffy null status and response with and without transplant after Revlimid, Velcade, Dex induction therapy in myeloma. There's very interesting findings on actually not seeing benefit from transplant as we once heavily rely on. And so really understanding what is driving those differences in disease and targeting those populations with appropriate clinical trials.
Yelek, go for it.
Yeah, so when we talk about solving this problem, I think we worry too much about the scalability of the solution, meaning if can we solve it in one area and then try to figure that the scalability, as opposed to trying to say we'll solve the problem holistically all across the US or globally, right? So in order for us to be able to do that, I think we need to do both a tops-down approach and also a bottoms-up approach. The top-down is the policy changes we need to implement and really continue to address from the national down. The bottoms-up approach is really making sure that we are engaging the community to increase awareness and provide support. Can we actually go into East Los Angeles here and be able to provide the education and the support they need in that area to connect them with City of Hope or others that are in this area? The second one is really making sure that the primary care providers are educated about what myeloma is and they are able to catch myeloma earlier in the patient's journey, hopefully before it manifests any of the CRAB situations. And the last one is really making sure that, Shonali mentioned this, there is optimal care and myeloma providers have access to the best therapies that are available for the patient. So this engage, educate, enhance, top to bottom and bottom to top access engagement model, and then scalability, I think really is important in order for us to be able to solve this problem.
Excellent points, Yelek. I think you're hitting it right on the head that there are options, there are processes, there are ways to be able to tackle this. We need to have the willingness, as all of us have identified problems. Let's take the next steps. And I've had the privilege of working with Rahul, for example, at the SWOG and NCI level, and we decided that okay, so we got to start somewhere. So one of the trials that just got approved has completely revamped the inclusion criteria to say, well, if you got myeloma and you need treatment, you should be on the trial. Let's do everything that we can to facilitate the patient going on trial. And then if we've actually even said that when we do the interim efficacy and safety analysis, we'll do an interim minority accrual analysis with it to see, are we heading in the right direction or not? So I'm glad that we are all talking about this problem and we are trying to address it. What I'm hoping is that today's very comprehensive kind of cross-disciplinary kind of interaction and discussion that we've had has given our audience not only a primer about the complexities of multiple myeloma care, but also how all of us are trying our best at our own levels to get the right patient to the right treatment at the right time. And hopefully all of this that we're talking about translates into not only those benefits in the clinical trial setting, which all of us are so proud to talk about. Craig has mentioned a couple of times, in a few days, we'll all be at the American Society of Hematology meeting, talking about how myeloma is leading the world and how we are just changing the kind of the paradigm. But I think it's also important to see how those clinical trial benefits and outcomes can translate to the patients sitting in front of each one of us and each one of the doctors across the country, irrespective of race, ethnicity, gender, age, living situation, rural, urban, whatever. We hopefully are able to provide benefits to everybody. But this was excellent discussion. Rahul, I'm going to hand over back to you.
Wonderful. Thank you all again. I could not agree more with it. Maybe what I can do is, until the i3 Health team comes back on, I will thank to all the panelists for your time. Thank everyone who's listening. I wonder if any questions have been submitted yet to the chat.
Yes, we do have one question, actually. Someone asked, can clinical trials be designed to make it more practical for rural and distant patients to enroll?
Excellent question. The short answer is yes, it's always possible. The trickier part is getting our partners in industry actually do it. A lot of them just, they're just to be negative before I'm positive. The negative part, I think a lot of, trial sponsors are apprehensive that if they allow for local labs, for example, or if they cut out the twice per month pregnancy tests, that the FDA won't approve this new trial that they spend millions of dollars on. But that's irresponsible, to be honest. And especially, I think, with the COVID pandemic, I think we learned very quickly that a lot of our requirements are dumb. You heard it here from me first, they are dumb. So I think a lot of the things that I'd like to see are being able to use local labs, using telehealth visits as necessary, spacing out visits, theoretically allowing for some drugs to be given commercially. It's tricky. A lot of these, but if it's an FDA approved agent, you're adding on an investigational agent, is there a way to kind of mix and match so that the local oncologist can take care of it? So it's possible. And hopefully with panels like this and with emphasis from all of you in the audience and those who listen later to this, hopefully it can happen. Thoughts that others on the other panelists have about this?
I think from the clinical trial standpoint, Kira, I would also point out a couple of things, just what we have tried, and hopefully they'll work. We'll find out whether they work or not, is we are allowing, some of the trials are now allowing for newly diagnosed patients to get some treatment even before starting the trial. So a lot of trials are giving, especially high-risk patients. We know that the disease is rapidly progressing. So patients can be stratified later on to figure out who got that one extra cycle versus who not, and we can still analyze results. So some trials are allowing local treatment before trial treatment. We, for example, changed our language. I kind of joke about it. When I joined Mayo, we used to have still a section in the protocol language talking about local medical doctor care. And while historically before COVID, it used to be always, nope, nothing's allowed up with a local doctor. But now post-COVID, we started revisiting that. And well, why not? Why can't we have telehealth? Why can't we have, because of these options in the rural patients who, I think Rahul nicely pointed out about the toxicity of time. How much time can a person take off from work? Are we really breaking the bank or providing them not only healthcare, but also a socioeconomic safety? So some of this is being done.
It's been really transformative in the past couple of years when I've seen sponsors of trials that have actually asked me, we want to decentralize this clinical trial. They're like, Craig, we don't want to have a clinical trial with you. We want you to find places out in the community that can do this clinical trial for us, to decentralize it. And all the time when sponsors say, are you interested in this trial? I try to assist them in finding places outside the academic centers where they can do that same clinical trial. Just because they haven't done, they weren't part of Determination, or they weren't part of Griffin trial, doesn't mean that they can't do clinical trials and very good work. And so I push them away from me. I hope Michigan State's not listening to this, and towards other places where they can get a capture of patients that's more diverse than what we would have at an academic center.
Very well stated. Kira, any other questions that came out? We can talk about this a lot. This is a big topic about the COVID for sure.
All right, yeah, that's the only question that we got tonight. So with that, I think we can wrap up. So thank you all for this incredible discussion. This is really such a valuable wealth of information shared regarding not only informing therapeutic selection, but also the strategies that can be employed to reduce these disparities. So thank you once again to everyone listening for tuning into this multiple myeloma task force. We hope you enjoyed the conversation tonight, and be sure to visit i3health.com and oncdata.com and subscribe to the i3 Health and Oncology Data Advisor YouTube channels, as well as follow us on social media to check out the other CME and CPD activities and expert interviews that we provide. So to all our panelists and to everybody listening tonight, thank you again for tuning in, and have a